Afternoon. I'm really honored and pleased this afternoon to present to you Mr. John Dent. He's a reader in both medical education and orthopedics at Dundee University, Scotland. And Dundee, it is a well-known area or whatever for innovation in general and innovation in medical education, and it's called City of Discovery, where the first ship moved from Scotland to the state. I came to know Mr. John about 1995 when he came first to the fair. Is one of the first medical education events at the University of Brazil. That time he was, both of them were very young. That time,
we were both very young.
Yeah, both of us, yes. And seeing them have a very good relation together. This is his third visit to Khartoum. He came, about 2 years ago for the third International Conference of Medical Education, when he gave a very nice talk on different aspects of medical education. He is a well-known figure in the area of medical education and orthopedics. Had a book which is known now. It is really a Bible of medical education for young colleagues. Very precise, very concise. Last week we had a workshop here in this center. There was a debate about the t-shirt, about the lecture,
yes.
And then we referred to your book.
Oh, very good.
So we referred to that book that this is a recent book about medical education, and it was written as a lecture, not as a presentation. That's the title of that presentation. So really, I'm very much pleased and honored to present John this afternoon. He's going to talk about a very important subject, and I think that will be an important foundation for our young colleagues dealing with clinical setting, teaching, learning, and this. We will touch on curriculum, and your course now is curriculum design, or program design, and then that will have a very good insight about this. So thank you very much for being here.
Thank you very much. Thank you for that very kind introduction. Thank you very much. I'm pleased to be here and meet you all. Please don't be shy. Please ask questions if you want to. As I go along, put your hand up and let me know you want to ask a question. It's a pleasure to come back to Khartoum and be in the city again and take part in helping other people learn how to teach and learn how to help other people teach. And that's the whole purpose of what we're all interested in, I think. Do you mind if I sit down to do the lecture? Is that okay? Yeah, thank you. This is a title which we chose together, and it's to ask this question. First of all, what do we mean by ambulatory care? Basically, ambulatory care is any place where patients come into a hospital setting but without being admitted as inpatients. And I wanted you particularly to think about areas of the places where students are taught, where there are opportunities for them to see more clinical material which aren't being used at the moment. There are often places which aren't being used for teaching which could be used, and that might help to take some of the students away from the very busy areas. And the question is how to do that and at the same time be sure that the students get a good exposure, get structured learning in the places where we've asked them to attend. So that was why I chose the title, The Role of Structured Logbooks to Support Student Learning in Ambulatory Care Placements, but I just wanted to be sure that we all understood what I meant by the term ambulatory care. Okay, so the question to ask ourselves are, where are there possible teaching venues? And I particularly wanted to focus our attention on the smaller peripheral sites which may be around the main teaching hospital. I know you have many teaching hospitals, many medical schools, but there may be in those areas, in the rural areas, ambulatory care teaching centres, or centres where people go for healthcare treatment, a health centre where there aren't many students. Now this is an example of such a place in Scotland where you heard I live. This is north of Dundee, which is the University Teaching Hospital, a small place 30 miles away where there is a small community hospital. Lots of things going on, lots of x-ray equipment, day surgery, investigations, but no students. So the obvious thing is to get some students and put them there and develop a teaching program for them. So that's one thing that I've been doing, and I want to talk a little bit about it with you. This is a view of Scotland, okay? If anyone hasn't been to Scotland, this is what it looks like, okay? So we have lots of hills, lots of trees, and lots of grey sky, because it's often raining. But in a very attractive area of Scotland on the west coast, a small town called Oban has a small district hospital, and again it is miles away from Dundee. It's, I think it was 63 miles away from Dundee. And we send groups of students there because they have surgery, they have medicine, they have care of the elderly, they have imaging, but not many students. So it's an ideal place to send people, so long as we can guarantee that any students who go there will get the same sort of deal, exposures to patients, as they would do if they'd stayed in the teaching hospital. So that was the reason. Now these are other venues, okay? You say, well, I don't actually know about any peripheral hospitals near my medical school. Okay, let's look in your own teaching hospital and or in your own regional hospital and say, where are there places where students could be taught? Everyone can say outpatient clinics. Tick, easy. It's overpopulated with students, I guess. Yeah? I asked the group this morning, in your ward, if you're teaching in your ward, you know, this is a small group teaching session. I said, if you're teaching in your ward, how many students do you have? Do you have 4 or 5 students around the bedside? No, they said, we have about 20 students around the bedside. It's so busy. And we want to think of ways of getting out of that. Maybe there are other units where you could go. Could you go to an endoscopy suite and teach? Could you go to radiology? Do you have a friendly physiotherapist department or OT department, speech therapy department? Could all these people help and take students for some aspect of teaching? I mentioned day surgery unit before, community hospital. It is possible, and I'll touch on this a bit later on, to create a dedicated ambulatory care teaching centre, and that might be something which would of interest those of you who are particularly going into medical education big time. Laboratories are often underutilised. The dialysis unit, a place where patients are tied down for a period of hours, and an ideal opportunity for them to engage in communication skills with students. And every time I show this slide, someone suggests a new thing, and the last time I showed it, people said, what about blood transfusion service? There's another place where you could send students to learn things, and there probably aren't any other students in that venue. So all these are ambulatory care venues, and they're all opportunities for student teaching. Am I talking too quickly? No. Too slowly?
No, you are all right.
Just right. Thank you very much. So that's the right answer. Okay, we don't need to see a picture of me in a clinic. Here's a clinic, an obvious place for student teaching. Here's a state-of-the-art MRI scanner in a small peripheral hospital, which we're now using for teaching. We send students there. The staff are ecstatic. Here are some students. We can tell them all about radiology. We really love radiology, and we would want to talk about it. This is great. Students can learn imaging. They can learn to interpret X-rays. They can recognize sectional anatomy and apply that to clinical problems. So a good resource. Friendly physiotherapists. I'm an orthopedic surgeon, so I need to have friendly relationships with physiotherapists because they help me with all those patients who I know aren't going to get better by surgery. So again, this is an area where we can engage with other healthcare professionals, and often they're interested in students and they're keen to help. Day surgery unit is an ideal venue because patients are coming in, being assessed, having their surgery, going out, requiring follow-up. This isn't just a chance to show students what an operation is like. This is a chance to show students continuity of patient care, what you might call a patient journey, from pre-operative assessment, assessment for anesthesia, anaesthetic procedures, surgical procedures, all the nursing post-op follow-up can all be learned. Who's going to look after them in the community? What help do they need in the community when they go home after a hernia repair or after having some upper limb endoscopic procedure, a laparotomy, outpatient laparoscopic cholecystectomy, home after a day or two. So that's an interesting place to see patients and to think about the continuity of care and a lot of teaching opportunities in that venue. Anyone here a pharmacist? Okay. In the group down the road at the Continuing Professional Development Centre where I'm speaking this week, There's a pharmacist. She's very vocal. She's very keen to teach medical students about prescribing, about drug interactions, about adverse drug reactions. And there's another place to send students to learn things which are important to them as future doctors, not just future pharmacists. Okay, so think around your place where you're working or where you will be working and ask yourself, is there any available space or resources? Tactfully approach an enthusiastic colleague, see if they'd be interested in taking a few students. Timetable, not too many, don't give them a lot at once, just give them 6 or 3. And do 2 other things. For the students, create a structured approach to learning so that when they go there, they can be in charge of their own learning. I think this is really, really important concept because as educationalists, we really have to turn things around so that we don't just recreate the style of learning and teaching which we had, like Professor Ahmed and I had many years ago, a very dictatorial, hierarchical system of teaching. We can turn things around and empower students to say, I want to learn such and such, please teach me about it. They need a structured logbook to guide them in directing their own learning in whatever venue you send them. And then secondly, your colleague, your clinical colleague, in whatever situation it is, may not know as much about teaching and learning as you do. So you have to help them with some staff development activity, whether it is a weekend conference, an afternoon conference, a lunchtime meeting like this, or whether it's printed material which you can give them, which will help them to do things about learning. And I'm going to show you an example of printed material later on about helping colleagues teach in different places. So these are new ideas and new things which may be possible. Well, this isn't just something in Dundee. Focusing treatment on ambulatory care is an international topic of interest. And this is a picture off a website from the Ireland Medical Programme in Vancouver, British Columbia in Canada. Here they have a rural community. They need to have ambulatory care facilities because people can't always travel from Vancouver Island to the mainland for routine procedures or tests. It's a long way from home. So it's nice to have things available there, but in that situation they've adapted an ambulatory care teaching program and made it suitable for students. So that's a good example from one side of the world. Okay? If we go to the other side of the world, to New Zealand, I was able to visit for a couple of weeks the University of Otago in the deep south of New Zealand. It's absolutely Baltic down there. If you go in the wrong time of year, it's freezing cold. Even for me, from Scotland it was cold. So don't go there. You wouldn't like it. Anyhow, down there, again, they wanted to develop an ambulatory care teaching facility at the university. I'll show you more about that later. In Australia, the University of Flinders University in South Australia has written a lot about their community program. Some of you may know about the community program there. Paul Worley and David Pridder particularly have written a lot about the community-based program, Parallel Tracks, how they have students embedded in the community in rural situations, and how those students learn by shadowing very closely and working with rural general practitioners. And in these type of ambulatory care situations, they've made a lot of progress in teaching. This is David Pridder there in the yellow, and Jeanette Greenfeld, who is the administrator, nursing administrator of their program. I had the chance to visit them. So this is an international activity of thinking about teaching not just in the teaching hospital, okay? I guess that's maybe not the right thing to say to establish teaching hospital like the University of Khartoum, University Medical School. But I think this is one way ahead and a cutting edge of medical education. Okay, so those are about places that you can find if you look around. And I want to suggest another idea to you as future leaders in medical education. And that's the role of a dedicated ambulatory care teaching centre. What we were able to do in Dundee, this is a picture of very near the entrance to our hospital. We were able to take over the use of 2 redundant offices on the way to our outpatient department. And these offices we made into 2 simulated consulting rooms, simulated teaching areas. So we made a supervised environment. We didn't use simulated patients or anything like that. That's all for the Clinical Skills Centre. But we did produce a supervised clinical teaching centre which was dedicated to student teaching in small groups with real patients. And it looks a bit like that. Okay, that's just a diagram, but you can see there are two identical spaces there, mirror images. They're furnished as though they were a GP consulting room or a hospital consulting room. There's an examination couch and things that make it look like a clinical environment, a desk, x-ray box. And there's chairs for everyone to sit, and a flexible divider so you can do lots of activities at once. But basically we can use that now as a place in which we can bring volunteer patients and teach and use them in small group learning. All people who are walking in, walking out, not needing medical care, but coming in to help us with the teaching program. Now, this is interesting because back at the University of Otago, they were keen that I help them develop a very sophisticated space like that. This space started off as being a badminton court in a nurse's home or a large acreage. And we could divide it up like this and make these teaching booths, which you see there in red, and a tutorial room and all facilities for washing hands and storing in kit. And part of it is for ATLS training as well, CPR training. And they opened it just recently, I think it's this year, May of this year, they opened it, and it looks very nice. And that's a dedicated ambulatory care teaching centre. So there's room in that for consultation, with real patients, but trainee students doing consultation skills, learning consultation skills, practicing consultation skills, practicing physical examination on people who've got a long history of abdominal surgery or ongoing bowel problems. Who's going to help teach in those environments? Obviously medical staff, but also trainees like yourselves may be engaged in teaching in that sort of environment. People who like teaching, a research fellow like this guy here in ophthalmology are engaged in teaching while their system goes on. Okay? So how does this work out then? You have a bank of patients who aren't critically ill, and you can invite them when you want to teach on whatever's wrong with them and bring them in and put on a structured teaching session. So you can use this dedicated space as to create bespoke teaching episodes. In my medical school we have 4 weeks where it is the respiratory system, another 4 weeks it's the cardiovascular system, and that pattern goes on all through our phase 2, years 2 and 3. For those 4 weeks or so, we want to expose the students to clinical skills training. We want next to expose them to meeting real patients. So we invite real patients who don't have anything wrong with them acutely, but they still have a history of their own, they still have physical findings, and this is the sort of patient teaching we can do in that sort of space. Now, one of the things about integration is to have an integrated approach. Okay? I think it's very important that we use the ambulatory care teaching centre, that supervised environment, in an informed way. And we want to use it for both vertical along the top and, vertical up the middle, and horizontal integration. Well, what do I mean about those things? From the student's point of view, vertical integration is when you're able to use your clinical encounter to remind them about things that they learned in the past. Maybe in phase 1, maybe they learned anatomy in phase 1 or year 1. You want to bring that anatomy back to life and fasten it onto a patient. If you like, you want to teach that anatomy again, surface anatomy, in relation to clinical findings when you're examining the chest and cardiovascular system of a patient who's had a heart attack or has high blood pressure. You might want to take the chance to revise physiology or even biochemistry. If you're good at it, you could revise biochemistry. And that might be possible. And this is all vertical integration, reaching back in the student's memory to bring to life things which they should be remembering, but fastening them onto something very topical and relevant to their future practice, a patient problem. Excuse me. Horizontal integration. What you teach in your ambulatory care teaching centre here should parallel, should mirror, should match what the students are experiencing in the clinical skills centre. So in their 4-week course, they're learning how to examine the heart and lungs, take history from people with chest pain. In the ACTC, they're seeing people who have those genuine problems and still have a murmur to listen to, so it matches that. When they go to the wards, they're seeing acute people with cardiovascular problems or acute respiratory problems. And in primary care, they're seeing the same sort of people in another context. This is interesting because students are learning the same thing now in 4 different areas. This is very important for learning, to integrate what they're finding, experiencing in different places. So here's an example of people learning ophthalmology skills, okay, and then they can practice those skills on real people in the ACTC because you've invited them in from your bank of patient volunteers. How can we support the staff who are helping us teach in this place which you've built up? We can put in all sorts of extra resources. If you've got a space with students and a patient in it, that's fine. Clinicians are very happy to teach like that because they're used to that. But what they can do in addition is have other resources available as well and use those other resources as to supplement the teaching. For instance, X-ray box, for instance, a video of examination technique, laboratory reports, a resume of the patient's case notes, and other printed material about the core clinical problem being taught. Sorry. Okay. And so you could have, in addition to the patient, some additional material, a scan, an X-ray, a synopsis of a history here about that particular patient. Again, these are things which the students can learn from, and it was all part of structuring their learning in this venue. The last thing I wanted to show you about this was about the patient bank. I mentioned calling in people from a bank of volunteers, so that when you need a patient who's got a history of a myocardial infarction, then you can call these people in and use them as volunteers towards the teaching. We were able to recruit people to this program in Dundee just by advertising in the local press. Last time I said this, last year at the workshop here at the teaching hospital, people said, well, we've got enough real patients here, we don't need to actually have a bank of them, there are enough. I think the only problem is you need to, if you want to run a timetable teaching program which is the same for everybody, you maybe need to have a handle on a group of people that you can call in when you need them, rather than just relying on opportunistic attendance. This is the difference. We're not just using people who happen to be in the clinic on that day. These are ones that we know what's wrong with them, we've got it all documented, we've got the good histories, we've got their x-rays, then they're all ready to be used to teach with. So that makes a safe package for the delivery of the teaching to those particular students. And it reassures the teachers that they've got someone there with a good story as well to teach on. How did it all work? This is a paper we published a little while ago now, having opened the ACTC for a spell. Students appreciated it. The tutors appreciated it because they were teaching there. They weren't teaching in the wards where they may get swept away with clinical delivery, clinical care delivery. The patients actually, the volunteer patients, often enjoy contributing to student education. I think it's a universal experience. Can a dedicated learning environment in ambulatory care improve the acquisition of learning outcomes? Well, we found that more outcomes were achieved. We could teach to more outcomes. We have an outcome-based curriculum. We can learn more outcomes or teach more outcomes in these outpatient settings, and this was a benefit to the students. So that's the first group of stuff I wanted to show to you. Does anyone want to interrupt me now and ask any questions? Then we'll go on to more about the logbooks. Yeah.
Hello. My name is Dalia Claire. I'm an assistant professor at the community medicine department here at this university. So I'm a little bit away from the clinic, but it's interesting. I'm trying to understand it, to translate it to community medicine.
Yes.
So is it an